really focus on, what we should really focus on is, after the screening, how many women are able to make it through the trial age and then the treatment. Because I feel we lose very many women from the time of diagnosis. After screening, not many women make it to treatment. And as an advocate who's creating awareness about cervical cancer, I feel this is a blow to us, because I think we're speaking too much, but what is done is little. Why do I say so? I ask myself, why are we having many cases of late stages in cervical cancer? And I think we are having a loophole between the screening and the treatment. Why do I say so? Our hospital insurance fund scheme does not cater for the expenses of screening, not screening, of biopsy and these other tests that one has to undergo before you reach the treatment. I should applaud them for NHIF, they cater for the treatment stage, but where we lose many women is these other tests that are to be done in between. So is it really wise for us to do the screenings and leave these women unattended to? Because I think many go home and they don't surface. Another thing is navigation. After these women have been screened and they are found out to be likely having this cancer of the cervix, who goes after these women to know how many have shown up to the facility to go for treatment? I think we are lacking there, and that is why we are really missing it. What I should advise our beautiful government, in collaboration with the other bodies that are helping to eliminate cervical cancer, can something be done about navigation of these patients? And also, the government should have statistics of the people that have been tested and the people that go back to report for treatment. I think there we won't lose these women and we'll keep a track of them. And I think the survivors, if we are empowered, we can help in doing this, because we're on the ground and we meet many women who we know physically. And as survivors, through the awareness that we create, many people come to us. One, we are hope, but this hope comes to us place and then is like, it's lost. Reason being, a patient comes to you, you've been through cervical cancer, okay, you made it through by God's grace and the treatment of the doctors. But now this one patient doesn't have enough funds or doesn't totally have funds to go for the treatment. We just see them dying. There have been even sad cases of women committing suicide because after knowing that they have cervical cancer, there's nothing they can do about it. It's a very sad situation. Then there's also stigma. These women go through a lot. We all know the parts that cervical cancer hit. So it's not something easy that a woman will come to you, tell you that I'm bleeding or I'm having a discharge that is not comfortable, because one, you are judged for being promiscuous. So I think more knowledge should be given to our people to know the causes of cervical cancer. Because the doctor one day, I was with Dr. Odongo, and he said, even just one time can cause you the HPV vaccine. It doesn't really mean that one has to be promiscuous to the HPV virus. So people have to be enlightened, people have to be talked to, and people have to be taught. And as a survivor, what I really come out strongly to advocate for is early screening that will go along with the tests and medication promptly, not leaving these women after screening. And another thing, let's just not talk about the awareness during only the January, which is the Cervical Cancer Awareness Month. I wish we could have more time that we could talk of cervical cancer. And during this month, you get very many people asking you, where do I go for screening? which means there's that gap. I think our government has to do more, create more facilities that will take up the women for screening. And another thing I'd like to talk about is the burden of the survivors. It doesn't just end with the treatment. That these follow-up tests that you have to be going to the hospital. Also, our health insurance fund doesn't cover up for all this. And you know, there's that fear of reoccurrence. How do we do away with this? Another thing is mental wellness of these people. If you talk to many ladies, they have been abandoned by their husbands. So maybe this lady was just a housewife and the husband walks away. And normally when the husband walks away, they leave them with the kids. So here's a woman struggling with the sickness. And as we all understand, treating cancer is costly here in our country. You have the burden of the children. As a mother, what will you choose? You will choose to fend for your children, and you will stop going for your medication because the little money you are getting is only enough to fend for the kids. I can't go to the hospital when I'm having 1,000 bob and my kid needs to eat and I go to school. So the MOH, that's why we say that we really need the survivors to be included in the policy making when it comes to matters of health, especially the hospital insurance scheme, so that we could really understand the plight of the patients on the ground. Thank you.
Yeah, thank you, Pamela. Thank you for taking us through the survivor's journey. We have had her presentation, how hard it is to have cancer, and she has advised on what we can do. So if you have questions, kindly note them. We will have a plenary session, and I'll usher in our second presenter, who is Gladys Mukosi, palliative care nurse, specialist, Kenyatta National Hospital. Kindly unmute and go ahead, Gladys.
Yes, good evening, everyone. You can hear me, Lillian?
Yes, I can hear you. Just make the presentation. Put it on a presentation mode. We can see your slides too. Thank you.
Okay, good evening once again. My name is Gladys Mukosi, as you've heard. I'm here to take this, how we are going to navigate this issue of stigma, as Pamela has well. And we need to understand what causes stigma, and especially in cervical cancer. We are going to define what is stigma, and we are going to see the impact on individuals, all holistic way, emotional, social, psychological. And then we are going to see the advocacy we need to do, and what we need to educate healthcare workers so that they can know how to manage this kind of stigma to patients with cervical cancer. So stigma is a negative and often unfair social attitude attached to a person. It often shows a perceived deficiency. Somebody will be feeling shameful and or a difference to their existence. They will feel like, do I need to exist? And the stigma, as you all know, it's a very complex issue that is well documented. Everywhere you go in the HIV field, you will hear of stigma. You go to mental health, you hear of stigma, but it is very challenging to overcome and even to manage. Stigma is a critical emotional and psychosocial barrier. It is a barrier to key social determination of health. It can prevent you from seeking health treatment. So recognition of the potential role of stigma to similarly undermine the cancer care continuum, particularly cervical cancer, prevention, screening, treatment is beginning to grow nowadays. Though evidence is very limited. We need to do more, and more so that we can have data on that. So stigma aggravates disease progression. You can get cervical cancer today, and then because of that stigma, you are just there and the disease is still multiplying or developing. So it hands on numerous socioeconomic, psychosocial, and health burdens, because sometimes you feel like, will I manage? As you've heard, it is very hard to manage cancer generally because it is very expensive. The NHIF is not covering everything. So if we come into socioeconomic, it is a burden. And it is worse in people with a reduced economical educational attainment, because somebody will just ignore and say, I don't need to go to the hospital. It is just something minor, all right. Do I need? But somebody who is knowledgeable, maybe you will see on the TV and say, oh, I saw it, it is manageable. And also exposure to psychosocial stressors. It is very worse to people who are, it is worse to people who are exposed to psychosocial stressors. Kindly people to mute. It is worse to people who have psychosocial stressors, because it will hard on that, and it is challenging to us. People will be challenged to access healthcare. So what we are saying is, studies have shown that 50% of people with the stigma will not be able to go to the hospital, or will not seek for health benefits. So what are the components of stigma? They will start feeling like people are labeling them. They will tell them, those cancer patients, you are already labeled, like that is your name. There is a lot of stereotype. Devaluation. Remember, these people who are suffering from cancer, they are human beings. They are CEOs in companies. They are people in the society.
I don't know what
but now
time
we have devalued.
Yeah.
And then there is a lot of devaluing. We tend to think like they are not people who are valued in the society. These are the people who are leaders in the community. There is a lot of discrimination because you came to the hospital, maybe you are discharging, you are stinking, and we are here, they are telling, that one, let her sit there because she cannot sit with other people. There is ignorance and prejudice. There are types of stigma, of course, about a few. There is stigma where people will just be looking at you and they are saying, this is a cancer patient. It's like we have baptized them. This is a cancer patient. We forgot their name. I'm Gladys. I'm not a cancer. There is that you see be like, even that one is going to die because they have cancer. It is not curable. You know, the way we stigmatize them, that is the public. Even in the community, when we hear so and so has cancer, what do we see? What do we feel? Institutional, even when they come to us, as professional as we are also stigmatizing them because we don't value them as people. We don't treat them with the dignity. We just treat them like a group, like we don't know they are supposed to live. And then there is also self-stigma, where you feel, how are people seeing me? I'm going to die. And then you start, it is wearing you down because you are feeling like people are seeing you like the other way, and it is not the other way. What about specific cancer, cervical cancer stigma? The link between cervical cancer and the human papilloma virus is a common sexually transmitted infection as stigmatized cervical cancer patients. Even when they come to us and we are taking history, the doctor is there asking questions. What did you, when did it start? We are there listening. How many partners? And when we mention that the patient, this HPV is transmitted sexually, we start feeling like, now this is a promiscuous woman. Maybe the husband is a promiscuous man. You know, we have already labeled this person. We have already stigmatized this person. And then I believe that cancer is contagious because we have said this HPV is transmitted from this man to this woman to this woman by a man. We already believe that it is contagious. And this woman will leave this hospital. By the evening, she's going to bring chaos in her home, and they are going to separate with the husband. Just because now the woman is quarreling with the husband. Why did you bring me this disease? So we need to know how to deal with them. How do we communicate that? Even if it is a sexually transmitted disease, there is a way we can transmit and it is not going to cause stigma. Also, cancer is a death sentence. Just to hear cancer, it is done. And yet, it is curable. When you come when it is too early, we can cure you. And even if it is in stage 3, 4, we can still treat and manage and attain quality of life, because that is the essence of what we do. Cervical cancer is a messy disease, as we have had. You can be discharging, you can be bleeding from January to December, and you can have all these issues, and then you feel like, I don't want even people to know. So we need to collect this person who is feeling like their life has become so messy. So given the increasing availability of both HPV testing and vaccination, because that is our target now as a government, it is important to understand the health beliefs and experiences that may serve as barriers. What are some of the beliefs which are preventing us from our agenda? Remember, we are talking about 90, 70, 90. We want to test people, we want to vaccinate people. What are the barriers? Do we know the cultures of people in the community, or we are going there and calling everyone, come, come, come? Do we know what we are supposed to say, or we are going there and talking blindly, like saying we are not supposed to have multiple partners? And maybe that is not a problem with them. We need to sit down with them one-on-one and discuss these issues, which are a barrier to all these things we want to do. This is a busy slide, but it has information of what I wanted to say today. Because as you start from the left, which is my left side here, there are risky factors of contracting HPV: lack of vaccination, early sexual engagement, multiple partners, HIV, and immunosuppression. All these are risky factors. And what are the drivers? What will make you? What are the drivers of those risky factors? Misinformation. Do patients have information? These are risky factors. We need to communicate them every day on the screens, on the phones, on WhatsApp. Lack of knowledge. They don't have information. We are here busy saying we want to vaccinate. Do they know these are the causes? These are the risky factors. Religious, cultural beliefs. I cannot overemphasize, because people have cultural beliefs. And when you come from the other side of the country and you are going to the western side of the country and bringing your own cultures from the other side, you don't value their culture. Remember, they also they need to be respected as much as we want to change. So how to communicate that is very important. Ambiguous messages, sexual transmission, association with cancer and death. I've talked about that. So how does this one manifest to stigma? Discrimination and attitude. I've already said, you have already told me, my husband is promiscuous. Stereotype, assumption of HIV status. We don't want even to go to the VCT to be tested. So we assume we are okay. How do we internalize that? We are feeling shame when you come to the hospital and you are told, now this disease is brought by this and that. Already you are starting feeling shameful. Maybe I'm a sex worker and you are here telling me this and that. I don't use protection. So what will come? Shame, self-blame, guilty. I'm feeling dirty and I've been doing all these things and yet they have given me the disease. Fear of death. I will not say like, if that is the case, let me go for testing. Let me go for treatment, radiotherapy. I will fear and then go away and sleep in my bed and in my bedroom and I will never wake up. Embarrassment. I will feel like embarrassed in the community. I will feel a lot of worthlessness and hopelessness. On the other hand, what is anticipated? Discrimination. People will start looking at me, and even when I'm with the other women, they will be pointing at one another. You see that one? You see that one? Then gossips come. Mistreatment by health workers, seriously. You came to the outreach, you tested me, you found the HPV virus, and then you go gossiping. So the healthcare workers are also promoters of the gossips. And then lack of partner support. Once you get this disease, as Pamela said, the husband ran away. When you start bleeding from January to May, my husband will run away. I have listened to many survivors, and they say, my husband used to tell me, I cannot continue swimming. I can go and swim in the ocean or something like that. That one translates, it's a message. So we need to support them as healthcare workers. So if you go to the other side, you see the decrease in the perception of risk. The way we perceive the perception, the risk, increase in sexual risk, the behavior, it is not changing. As much as we are talking, we are seeing even what is happening in our community today. Sexual engagement is just like normal thing, and not with one man, man to man, woman to woman, woman with 5 men, like that. Denial, avoidance. We don't want to be seen. We don't want to be told I have cancer. When I am told I have cancer, I go to bed and I go into depression and then fear. And as you see those boxes, they are all translating what we are going to say. Lack of screening, fear of positive diagnosis, the microphones and saying it is free. Discomfort with the procedure. Pap smear. How many women go for pap smear? That procedure is so hard. Lack of trust with the providers, have emphasized on that. Lack of treatment, update and follow-up. Yes, it is important for us to tell the patients, and especially in the navigation. We need to strengthen the navigation. When we treat you and we are finished, these are the side effects you are likely to experience. And when you finish, there's something we call follow-up care. It is very important. When you go home after 3 months, come, we check again whether you are okay. Because if you don't come and we will stay for a long time, after 3 years, these are the people who are coming with a recurrence, and then they are wondering, what did the doctor do? We did not give them proper information. And there is also mistrust, denial, financial burden. That one we cannot talk. If we start talking about burden of the finances, we can talk until tomorrow. So how do we mitigate all these I have said? Peer-to-peer outreach. Whatever Pamela is doing and the others outside there is very important. You talk to people who have given hope, who have lost hope, and they come back to life. You talk to them, you counsel patients, you give in education, and they come back again because they think, when I was diagnosed with cancer, that was the end. HPV screening via self-collection. Do we have these tools? It is important for the government to provide such things because we don't want to go and open our legs to the doctor, and especially to a male doctor. And if it's a woman who is older than me going to open my legs to a young girl, it is hard. Stigma reducing messages. We need people to come up with skills of ICT to bring out messages. Even when we are talking, when we are in matatos, we can see stigma reducing messages. When they come to the clinic, to the hospital, we are able to talk to them. This cancer is not a death sentence. We are going to take care of you. We are not going to abandon you. When we start treatment, this is going to do this. The treatment is going to give you nausea. The treatment is going to give you stenosis of this, but we are going to give you how to navigate all those things. Availability of treatment. We are talking about screening. We are talking about testing. Do we have available treatment options in the country? It is a challenge. Every morning I wake up in my clinic and I see patients queuing. There are over 100. And by evening, the patients have gone. They have been told there are no treatment. Machine has broken down. What are we doing as a government? We need to back, because if we want to continue talking about cervical cancer-free country, we have to wake up as a country, as a person, as a survivor, as an advocacy, as everybody. So what are we advocating for? Cervical cancer awareness. It is not only in January, my friends. We need to wake up every month. We need to wake up every day and talk about cervical cancer screening, cervical cancer prevention, cervical cancer vaccination. Let it not be a business of January. If it is January, by the time it is 2025 January, we are going to have more deaths and deaths and deaths. Let it be a business of every day. Because cervical cancer is one of the most preventable and treatable types of cancer. Screening and vaccination are key to prevent cervical cancer. And I will one day be happy when I will hear there are no deaths of cancer, cervical cancer. So screening and vaccination, yet in 2020, just the other day, more than 600,000 women were diagnosed with cervical cancer worldwide, and almost 350,000 died from the disease. That is a worrying statistic. So what are we doing? Dr. Jennifer here is telling us we are at a historic moment in the time. We can imagine a world with which there will be no women dying from cancer. Are you ready to be counted in that historical moment? Are you ready? If you are ready, speak to 2 women every day about cervical cancer prevention. What are you doing as a person? What are you doing as a nurse? What are you doing as a doctor? What are you doing as a social worker? Everybody, cervical cancer can be prevented. We are doing something. Let it not be the government is doing something. Gladys is doing something as a palliative care nurse in Kenyatta. So and so is doing something as a nurse in MTRH. Let us raise our voices. Let us talk. Talk to patients. Talk to our colleagues. If you hear somebody talking to a patient in a bad way and you are in the hospital and this patient is coming with cancer, tell them, please, this is a human being. This is somebody who has come from a home and they have come here to be treated. So we need also to decrease stigma by quality support. We need to support our patients. The support we give them is the gateway of cure, of treatment. If they come to the hospital, give them that supportive welcome. Give them, in the morning, greet them. Call them by their names. Gladys, how are you today? And then the treatment, let it be standard. Let there be availability of treatment in the hospitals. Talk openly about these things. Don't hide anything. The people think, sometimes I am so open because me, I will say, this is this. It is not that. Because when I'm talking about sexuality to a patient who is starting radiotherapy, and I know very well this is somewhere where at one point you will come back and tell me, my mzee, you said it cannot pass. So why are you talking like you are talking in parables like Jesus? Just say, when you are starting treatment, we need you to dilate that area. And if it is possible, even the husband, you can continue with your sexual relationship, because that is also a way of dilating. One time I was challenged by a couple I was counseling. And when I was talking about dilating with a finger or you buy a candle, the husband challenged me and told me, what is the difference between a candle and me? Why can't I do it? And I was like, oh my God, we need to give them a lot of education. Education, when you see this, you are supposed to come back. When you feel this, this is supposed to happen. We work with them from the diagnosis to the end. Remember, survivorship is not after treatment. Survivorship starts when I was diagnosed with this cancer. I started surviving. And after treatment, I'm surviving. So we need to give them a lot of education. We need to talk in the media. I want to praise Brenda, my colleague, my friend, who is ever on the screens talking about these things. Media, WhatsApp, where? Personalized role. What is my role as a palliative nurse? What is my role as an oncology nurse? Let us talk. What is my role as an advocate? Communication. Can we have effective communication, not just communication? I usually tell my colleagues and the doctors and nurses, you can be a very good doctor, you can be a very good nurse, but when you don't know how to communicate, you are the worst. Let us talk to our patients in a language that they can understand. Let us be sensitive, even as we talk to them. Let us be empathetic. Let us put ourselves in their shoes, because they are hailing, and they are, I said, and I want to repeat 100 times, they are human beings. Remember, this is a mother of somebody. This is a sister of somebody. This is a wife of somebody. So as we communicate, let us imagine I'm the one. How would I be feeling? Let us encourage them. with the good words, so that they can bring a face of strength, so that one day at the end of the treatment, they can say, cancer in many ways saved my life. Through dying, I learned how to truly live. How many will say that when they are gone through your hands? Or they will say, just to say, when will I ever finish this treatment? I will never come back to this hospital. Let us be an instrument of change to these particular patients. Can we stop stigma? Let us respect our patients. They are human beings. Let us support them. Let us help them during recovery. As we start with them, promise them we will never abandon them. That is what the patients want. That is what which I usually win my clients with. I promise them, my dear, I will not abandon you. Unless I'm on leave, but I'm just a call away. You can always call me. You can always inquire from my colleagues what you are supposed to be done. Give them information. Let us all stop this issue of stigma and let us love our patients. And I think that is the end of my presentation. And thank you so much for listening.
Thank you, Gladys. That is very informative, and I believe we have learned a lot from the definition of stigma, the impact that it has on individuals, and also we have got some advocacy in it, and we have learned a lot. And probably if you have some questions, put them on the chat. We will answer them at the end of the webinars. So we are going to usher in our next presenter, Benda Kidhaka, with the post-treatment concerns and quality of life. Welcome, Benda.
Thank you so much, Lillian, for the invitation to speak today. And I'm just going to put up my screen. Please confirm you can see my screen. Is it visible?
Yes, very visible.
Fantastic. Thank you. So my name is Benda Kidhaka. I'm here to talk to all of us about the breaking barriers, post-treatment concerns, and quality of life. I will be touching on both physical, emotional challenges that survivors face, as well as sexual health and intimacy after cervical cancer. And because the two are quite interlinked, I will spend a bit of time speaking about the physical, emotional, sexual health, and intimacy all in one, so that we can have a bit of a dialogue around what are the things we can do. I am a health advocate with Kilele Health. We are a non-profit based here in Kenya, working across Africa. We equip patients, survivors, and caregivers on how to use their lived experiences as tools for policy advocacy, community education, and behavior change communications, both for disease prevention as well as for disease management. Kilele is a Swahili word. It means reaching the top or the peak of our ultimate health goals. And we are advocating for survivorship as a link to cancer prevention. We are a member of KENCO, the Kenya Network of Cancer Organizations, the NCD Alliance of Kenya, Kenya Society of Hematology and Oncology, the Union for International Cancer Control, and the African Cervical Health Alliance. And we're based here in Nairobi, but we work across Africa. And in Kilele, we work to deal with climbing real or even perceived mountains. Here we talk about real mountains like climbing Mount Kenya. Every year, our survivors take on the challenge and they go up the mountain, and so that they can educate people that cancer is not a death sentence. But also we deal with the physical, the mental, the social, spiritual aspects, and even financial aspects of surviving cancer. And we are providing skills and exchanging knowledge and ideas on how we keep our communities around survivorship and survivorship care. So let's define what is survivorship. Most often people assume that survivorship kicks in after treatment, but a survivor or a cancer survivor is anyone with a living history of cancer, starting from diagnosis through to the rest of their life. And I'm emphasizing we know that from when somebody is diagnosed with cancer, there are a number of things that pertain to the treatment, but there are others that pertain to managing the disease and managing the person's life and quality of life. And then we also in Kilele work with caregivers. And this is because we've recognized that you cannot have survivorship without caregiving. Caregiver is anyone who is either a spouse, a partner, a family member, including children, as well as sisters, brothers, cousins, or close friends who are walking the journey with a cancer patient, and often they're not paid to do so. Secondary caregivers are people like yourselves who are on this call. Majority of you right now would be either clinicians, physicians, nursing staff, oncology nursing, oncology caregivers who are working in the secondary provision of care to the survivor, that their journey may be easier. And when we look at survivorship stages, we have acute survivorship, which starts at diagnosis to the end of the initial treatment. Here we're talking about the patient, the caregiver primary, and the caregiver secondary are concerned about how do we manage this disease? How do we treat for the outcomes that have been identified? For cervical cancer, for example, if it's pre-cancer of the cervix, management of that condition will be, how do we manage to ensure we retain fertility, we ensure quality of life of this woman, and we ensure that it is the shortest time period to recovery. When we are talking about late-stage cervical cancer, then the diagnostics, the treatment, and the care outcomes will be different. And this is where we talk about acute survivorship. Extended survivorship is somebody has gone through the treatment. After they have been, so for pre-cancer, there is the either thermoablation or called for biopsy and LEAP. And at that point in time, we're looking at a few months after that, they will need a follow-up to see whether indeed the cell changes have cleared, the cervix has regenerated, and what is going on with their life. And it also deals with the treatment after effects. For example, when we talk about in pre-cancer, the after effects could be this woman has gotten her fertility preserved. She wants to get pregnant. Has somebody talked to her about the cervical sutures that she needs to receive to make sure that her pregnancy is safeguarded? Because the risk could be that at a later stage in pregnancy, she could lose that pregnancy. So extended survivorship is a few months into a few years of survivorship after the treatment has commenced and even sometimes has finished. Lastly, there is permanent survivorship, and this is where we're focusing about years and years after treatment. In oncology, we talk about the 5-year treatment, post-treatment survivorship, where then we can say the person has been checked, there is no evidence of disease. They are told, go home, you're fine. We will now be doing regular checkups maybe after a year or 2 years. But there is a need for continued checking of long-term effects and recurrence in cancer. And so with survivorship, the moment a woman is diagnosed with cervical cancer, from pre-cancer through to late-stage cancer, the acute, extended, and permanent care needs to be taken into account. Now, when we talk about that, then let's talk about what does the woman go through when they are told you have cancer. One, from our lived experiences with our survivors, we've learned that the news is often received with shock, disbelief, anxiety, fear. There is anger, sometimes grief, there is loss, there is pain. There is also anticipation. Sometimes there is the self-doubt, like my colleague Gladys was speaking into, talking about here is a woman who is diagnosed and she's also being stigmatized. So with multiple sexual partners, there is this messaging that's going out that this woman could have been promiscuous, when we know potentially it might not even be the case. It could be that the previous partners with the husband could potentially have brought this HPV, and the woman is being stigmatized. There is the self-doubt of, will the recurrence occur? What choices do I need to make about my sexuality? Am I even functional as a woman now that the cervix has been removed? Now that I've had a radical hysterectomy? what are my options in sexuality? Lastly, there is always the question of dignity and quality of life. And for quality of life, we define it in 4 parameters. There is the physical. So with cervical cancer, there is the question of the vagina and how it is affected. There is the question of the cervix. There is the question of the reproductive organs and how she is affected by that, and what comes with the image of what she has gone through. There is the mental and psychosocial and psychological. The thought that potentially, am I still a woman? Can I still enjoy sex? Am I still validated as a woman? Can I still have intimacy with my partner? Do I still look attractive? If chemotherapy and radiotherapy have happened and she's lost her hair, concerns again around personal function, physical function, social and spiritual quality of life, where stigma features heavily, where the fear of what is happening to me, questioning their religious beliefs, questioning their spiritual aspect, like, what is this? What does this mean? Why would God let this happen to me? And therein comes the question. I saw somebody ask, where does the religious organizations or their spiritual counselors come in? This is at the social quality of life, where they can be able to also offer messaging and interventions that can validate and help this woman reintegrate back into the community. The last one on survivorship quality of life is financial. And we know from diagnosis through to treatment, through to survivorship, cancer is an expensive disease to treat, and especially when found in late stage. And therefore, there needs to be interventions that look at a life beyond the illness into quality, affordable, accessible care for the woman during, before, and after treatment. Some of the concerns that we faced with our survivor community relate to the side effects of treatments, the outcomes and recovery. How long will it take? There are the cost implications. How long do they have to stay in hospital? Who takes care of their children while they're away? Who takes care of their family? And even tolerance to the treatment options that they have during treatment. Before treatment is prescribed. During treatment, there is the question of fatigue. There is the question of quality of life affected by diet, management of self. There is the question of recurrence. There is the anxiety and depression that comes with cancer. There is the seeking the balance between getting self-care, caring for others, because we know women are nurturers, and caring for the community around them, because they are also concerned about the people that are taking care of them. And after the treatment, there is the concern around the continued fatigue, the fear of recurrence, getting strength to carry on with life after treatment. Sometimes, because of the kind of treatment that they've been taken through, there is even lymphedema. And we're talking about swelling of the legs, which also affects quality of life. Some of the interventions that we have could also affect the heart function, and therefore leading to cardiac disease and overall quality of life. Expanding on this and now getting to the topic at hand, sexuality and sexual reproduction, and having the conversation around the quality of life in sexuality for cervical cancer survivors, some of the key things that we need to think around include even family planning and fertility. Yes, family planning and fertility. Because in cervical cancer, especially when we get it at the pre-cancer stage, that woman still has the potential and capacity to bear children. And we need to have conversations with a woman from the diagnosis point to find out, do you still want to have children, or are you done having children? If it's at the pre-cancer stage and we can preserve that fertility, then options ought to be given to the woman before treatment starts, so that then there is that conversation around what period can she be able to conceive. How will we ensure that she gets to full term? How will we ensure that the quality of life does not compromise her ability to have children? And for the women who are in advanced disease, we need to think about what are the potential side effects. We need to talk about, for example, things like vaginal dryness, things like tightness because of radiotherapy and brachytherapy. we need to think about strategies that can help in mitigating side effects. And I know Gladys, you spoke about the husband being one of the mitigating solutions to vaginal dilators, for example. And for me, talking to survivors and knowing the issues that they are dealing with, from even the mental wellness, the physical wellness, the intimacy concerns and the fears, I would say we need to empower the women to own their sexuality before we start subjecting them to sex and intimacy with their husband. Because consider this, he may not know that, for example, because of the tightness and the dryness of the vagina, because of the treatment that she's going through, he may not know how much force or how much gentleness to apply, because for him it's a sexual function. But for the woman, there is a question of how gently can she insert the dilator, or how quickly can she go back to that. So strategies to manage and mitigate side effects need to be included. Intimacy and relationship dynamics. We often assume that sex and sexuality is about having penetrative sex. But working with survivors, working with their partners to manage and navigate the intimacy issues and healthy sexual relationships, we may find that we do not even necessarily need to have conversation about penetrative sex. And therefore, I'm talking this boldly because I know I'm talking to doctors, medical practitioners, and therefore we can have this conversation without fear of stigmatizing this conversation. So what I'm getting at is we need to think about comprehensive survivorship care where women are concerned. And for that to happen, we need to start from the word go at assessing the sexual function. This is not just about treating the cancer. It's also about treating the whole woman, thinking about her vaginal health, thinking about her sexual health, thinking about how will we deal with the after effects of treatment, that the discomfort, the tightness. How will we deal with the dryness? How will we deal with the emotional aspects that affect her libido, her arousal, even her ability to have orgasm? We also need to think about how do we communicate honestly and openly about the sexual concerns that they have, so that we create safe spaces for them to climb that mountain and get to the top of it with confidence and with dignity. We also need to have conversations around at what point do we refer the woman for further care, because in our capacity, we're not able to address the sexual health or the reproductive health or the emotional aspects relating to body image, anxiety, depression, concerns that they may have that are valid. At what point do we start prescribing vaginal dilators, for example, or lubricants, to make sure that this woman can regain her confidence in having sex, and therefore sexual rehabilitation and sexual health rehabilitative support? Here we're talking about even considering taking action to refer to other specialists that could lead to better sexual health. And lastly, in terms of follow-up, monitoring and evaluation, to make sure that there is continuous conversations, making safe haven for us to have conversations beyond the cancer into sexual health, into adjusting to the new normal and adjusting to the new life. This is where survivorship kicks in, and I'm very proud of our Kilelean survivors, specifically because survivors in Kilele have come and said, yes, we know we're surviving. Yes, we're working towards thriving. What else can we do? And this is where having a support group such as ourselves, Kilele, we've made sure that our survivors can share their experiences and share anecdotal data and information that can help others cope better, walking the journey together. Secondly, having resources that can and materials that can help address sexual health and sexual behavior. Lastly, survivors have gone a step further. When Gladys says, I'm forever on TV, no, I am no longer on TV as I used to be 14 years ago, 13 years ago. Now our survivors are the ones taking the airwaves, most often talking about the need for vaccination so that we can prevent women ever getting to that need for cervical cancer treatment or cervical health rehabilitation. Secondly, the need for treatment and the need for access to palliative care, so that we're vaccinating 90% of all girls, we're screening 70% of all girls, and treating 90% of all women found to have anything suspicious. There is the other group that is often forgotten, girls ages 15 through to 25, at which point parents start asking, where is the husband? And the health system starts saying you can go for screening if you've been sexually active, if you're HIV positive. We need to inform, equip, and educate these girls early to know their risk, that it's not just about the risk of cervical cancer, it's the risk of future sexual health, so that they start understanding that taking charge now means taking care of yourself now by getting vaccinated, by getting healthy sexual practices and healthy sexual behavior, and being aware, self-aware as well as partner aware, so that in future we can prevent cervical cancer. But lastly, in Kilele Health, we've started training of counselors supported by Amani Counseling. We have 13 survivors right now who have been trained as counselors. And these are women and men who have been taken through intensive trauma counseling, so that they can become agents of change in the community. So that when you are practicing oncology and you need somebody who can speak to the survivors from a point of understanding, or from a point of diagnosis and understanding, then we have people who have been trained on how to do it professionally. What we are looking for is opportunities to integrate them. We are not sitting waiting. We have the Project Thamani Yetu, which currently is a survivorship reintegration program, where we have our survivors engaging in policy, representing the voice of the survivor. Just this last week, Monday, the government of Kenya had, through the Ministry of Health, had the National Cervical Cancer Commemoration Day in Taita Taveta. In Kilele, Benda, I did not need to travel. We were represented by survivors, because we want them to engage at that point to say, we're here, we can no longer be ignored. Secondly, mainstream media engagement with lived experiences, so that we demystify, destigmatize, and build awareness. Thirdly, social media through storytelling. When we climb mountains, we encourage them, go tell your story, so that we can get as many people as possible to understand cancer is not a death sentence. We're looking for opportunities to demand creation, especially because we want the vaccines to move. We want our girls to be vaccinated so that we can prevent. Secondly, in community mobilization, when you have, as hospitals, as clinicians, when you have community outreach days, call on us to give you survivors who can speak the lived experiences. And this way, it is not about they and them, it's about all of us as a community linking to services and linking to prevention. Thirdly, access to care. We are constantly engaging with industry, constantly engaging with innovators, so that we can ensure that there is access to care, there is navigation for care, and there is reintegration of survivors. And lastly, when we say messaging is important, sensitive messaging that is culturally relevant, that is one of the other things that we're doing with survivors, because ultimately we know cervical cancer is preventable. Cervical cancer can be prevented. We have the tools, the mechanisms, and the ability in Kenya. What is lacking is the action, and therefore we are catalyzing action. I said again, we as Kilele are working towards quality of life in survivorship as a link to prevention. In Kenya, we work with cancer survivors and caregivers. Across Africa, we are working with other civil society organizations, so that we can be able to build this narrative that cervical cancer needs to be addressed now, not in the future. Today is the day that we need to get Africa equipped across countries for us to be able to beat cervical cancer. And lastly, we also engage with various influencers, various community engagement partners, so that we go to schools to mobilize, we go to communities to talk about it, we go to policy forums to talk about it. And when I say we, majority are the survivors that have been equipped with knowledge, expertise, and skills to go to the community and reach people with the knowledge that cervical cancer is preventable. Various partners that we work with, some of the messages that Kilelians have said is that Kilele has been a pillar of hope and strength to many survivors. It has helped shape not just the physical, but the mental tenacity, business acumen, and spirit of not giving up. Secondly, Kilele has increased self-confidence when life was tough and they felt like giving up, but they have given them a push. And lastly, in Kilele, we have fun in building relationships, building a family of Kilelians, and always working towards safeguarding cervical health for every woman and girl. Thank you so much. And that is the end of my presentation. Thank you.
Thank you, Benda, for taking us through that very informative presentation. It is true, if we do not look into how we communicate, how we care about the survivors, we will be doing an injustice to life, because even survivors or those who have cancer or cervical cancer, they are still human beings, and we need to save life through communication, good communication, and taking care of them. So I will open up this session now. We go to the question and answers. So the questions that we have for our panelists today, so that they could be answered. So Maureen Owiti is saying, kindly emphasize on prevention. There are vaccines being thrown away, and current data shows no cases on cervical cancer in vaccinated population. I think that's when, as healthcare workers, we know about the HPV vaccine. I can take that. We know about HPV vaccine. And as Benda said, that we go on communication, even Gladys says, remember we said 90, 70, 90. So the 90% of these girls are supposed to be screened, and it is quite easy. It is simple. It is 10 to 14 years old, 6 months, 2 doses, 6 months apart. And the girl is vaccinated against HPV virus. That one we should do advocacy and let the community know about it. It's only that they don't know. Once you are in the hands of the doctor, you will believe anything that the doctor tells you. We have the power in our tongue. We talk to them and make them accept vaccination and do away with the myths. So we have somebody saying, is there any form of support offered to a needy patient who has developed incontinence post-treatment with radiotherapy? She has had to travel up country because of lack of resources to even buy diapers, and she's now deteriorating. I don't know who can take that. I think it is still support. I think, Benda, can you take that?
Yes, I can. So, so the question was, the woman needs psychosocial support offered to needy patients for incontinence post-treatment. She traveled a country and, okay. So I think that is a big gap that has been highlighted by the anonymous attendee. The reason being, we know quite a number of cancer civil society organizations in Kenya are based in urban centers, and that's where psychosocial support that is offered in terms of even getting diapers, even in getting rehabilitative surgery is offered. So I would say the person who asked this question, if you would find out if there is a center near the patient that is also registering people for treatment of incontinence through surgery, fistula treatment. If you can find out if there is a center like that, then she would be eligible so that we ensure that the incontinence is taken care of. But secondly, I think linking them with Kenya Network of Cancer Organizations so that we know which support groups are in her region would be a helpful opportunity for her to also be able to deal with some of the psychosocial support that she requires. Thank you.
Okay, we have another
Maybe
one.
I can also
Yes.
add on that question, Lilian.
Yes, go ahead.
I'm imagining this is a patient who has gone through radiotherapy or chemoradiation, and maybe she has gotten fistula, or because of the cancer itself, she has gotten the fistula. But as I want to unpack what Pamela was sharing about, we need a strong patient navigation program. As we have a patient navigation program in Kenyatta National Hospital, the government, this is the high time the government should take the copy paste the patient navigation program, what we are doing, and make it better so that we can do a follow-up of these patients. And we do a follow-up of these patients because we call them at home and find out how they are doing. But the patient navigation program has no capacity of calling everyone. So this is a patient we can link to the nearest palliative care station, and they are going to take care of that gap, and they are going to see how they can help through the office of the social worker. They can provide some material like diapers. So maybe the person who asked that, you can link me to that patient. I'm going to find a solution for that patient tomorrow. Thank you.
Thank you, Gladys, for the additional. So we have another question. What is the role of the church and spiritual leaders in reducing stigma? Gladys?
The role of the church in reducing stigma, I would not say it is a very strong per se, because not everyone who is a believer. If you tell somebody who has been diagnosed with cancer and she's experiencing stigma, and then you tell her, come kuja nikuombe, truly speaking, maybe you are hurting the patient more, because one, they are there with a lot of bitterness. Why did God give me this disease? So the role, it will only work for that person who is already cured from the stigma and the denial, and the patient is calm and now is able to make an informed decision. I need to go for counseling by a pastor. I need to go for counseling by chaplaincy, something like that. But it is a very helpful thing when they are in stigma and they are in that crisis. The staging Benda explained, when they are in crisis, kindly let them choose what they want, not you to impose what you want, not to call the pastor for those people or the father to come and put oil on them. That does not make sense at that particular time. They will only make sense when you have navigated them well and they are now starting to accept and see the reality of things. Thank you. I don't know whether I've responded to you.
Thank you, Gladys. I think there's a comment here. I'll just take it as it is. Stigma is really bad, but preparation by health workers is not forgivable.
Sure.
Not a lady on treatment for breast cancer had nurses in the chemotherapy ward of a prestigious hospital say, huyo akona alama ya jeshi. They were referring to mastectomy. I would say that is so bad. From what we've just learned, that was quite bad, and we shouldn't do that at all, from what we've learned today. So our next question is, what are the first signs of cervical cancer and what indicators should someone look for? Okay, today we were not doing cervical cancer per se as a disease, but I may mention that cervical cancer, initially when it starts, there is no signs, you will not feel anything, but by the time you are seeing the signs, which are you could be, the woman could be having postcoital bleeding or postmenopausal bleeding or coital bleeding or having discharge, which is not normal. That time it's already a setting as cancer when now the woman is now seeing all those signs. And the only thing you can do is to go for screening. That is when an early diagnosis can be done, or at whatever stage can be done. So there is no indicator, anything that you can see from the cervix if it is not looked into by a service provider. No woman can see their cervix, so they can only see those signs when now it has set in. So prevention is quite key through screening that is done in the facility. There is PV bleeding usually associated with family planning, drug hormones. How can one differentiate it with one that associated with one caused by cervical cancer? I think that one, the woman would visit the facility and believe the doctor, the gynecologist, or the nurse attending to the woman will differentiate both, because they will be screening during that time and they will know whether it is due to family planning or it is due to something else. So the only way is to see a professional to check it, to give a diagnosis, a proper diagnosis on what that bleeding is. So problem I have is that I keep asking for recordings. No, sorry. Recordings may be shared. Thanks so much for the wonderful presentation. Kindly, is it possible to have buddies, especially the survivors, for support of our clients who are ongoing treatment, Benda, maybe that one you can link up with Veronica.
Yes, Veronica, I'm going to type up our Kilele Health website where you'll be able to pick up all our contacts. And if you can contact us, we'll be able to link you with survivors who are already counselors or who are already champions for prevention. And so that then you can be able to have that buddy system. We welcome you to Kilele. Thank you. And where necessary, if it's out of Nairobi or the other centers that we don't work in, we can also link you with other KENCO members so that everybody is taken care of. Thank you.
Oh, thank you, Benda. I say thank you everyone for joining the call. Our time is up, and more questions that you have answered, some of them we will answer in some continuous webinars. We have MDT webinars for healthcare workers that we are having monthly as National Cancer Control Program, where we learn about cervical cancer, breast cancer. So kindly, when we share, please join and then we learn more. You can come up with your own MDT series, like a case study, and we discuss it there and we get solutions. So thank you so much for joining. My name is Lillian Genga, working with National Cancer Control Program. I was the moderator for the day. Bye-bye.
Bye-bye. Thank you so much for your attention.
Thank you everyone for joining us, and thank you for engaging so robustly. Thank you.